هيكون لنا في الآية القادمة إن شاء الله. So thank you all for your dedication and attendance today. We would like to welcome you in the panel discussion. This is, I believe, it's one of the hot topics that we are going to discuss. It's sharing experiences during complex emergencies, with of course some highlighting or full highlighting of the status in Sudan. Professor Ibrahim Bani, the floor is yours.
Thank you. Good morning, everybody. And thank you all for joining us for this important panel discussion on sharing experiences during complex emergencies. So today we bring panelists from diverse backgrounds and each offering a different perspective, a very unique perspective on this important issue. So let us start by specific issues and the format of the panel. First, there will be presentation and talks, followed by specific questions to the panelists, then general questions to the panelists, and after that we will open Q&A. We'll sign them we have takeaway message. الجزء الأول هيكون عبارة عن presentation talk. Our first panelist will be Dr. Muhammad Omar Tahir, who is a senior consultant psychiatrist at Hamad Medical Corporation. He will share his experience. The floor is yours, Dr.
Thank you, Professor Bani, and thank you all for coming. I'll start by just introducing the topic to you, which is about support, social support during crisis or disasters. And obviously, we need to make some objectives for this brief presentation. We want to just define the psychological effects during disasters, understand the social phases and mechanisms in disasters, and then from that we will reflect on some of the psychosocial needs of the population at the time of disasters and prepare for the panel discussion from this brief presentation. You know that the United Nations defined kind of disasters as the kind of situations where the resources will not be enough to compact the needs of or to meet the needs of the population during the crisis period. And disasters can come from different, they classify it from different means, by different ways. Mainly, we have three categories of disasters: the natural disasters like floods, earthquakes, which are quite common, and technological disasters like, for example, if you remember the tsunami in 2004 and the leak of the radioactive materials from the so that's a technological disaster. And human disasters, obviously, are wars, are the examples, and this is what we are facing now. In general, disasters occur over the world, and there are areas which have higher rates of kind of disasters or crisis. Philippines counts as the kind of number one in the world in the number of crises per year. Sudan is not actually at the top, but in the classification, Sudan comes as one of the most vulnerable areas where the resources are not able to meet the needs if there are disasters coming in that situation. The psychosocial effects of disasters are well known as well. This slide is kind of picked on from some of the guidelines from the British guidelines on response to disasters. And there are four phases there. The first phase is usually at the time of the disaster. There will be what's called the heroic phase, where everyone will just try to do something quite heroic. And there will be a lot of kind of activities happening at the time. And then we'll come to the phase where everyone will put in their resources. You will see the movement of resources from outside the places and organizations, whether national or international, from everywhere. So there will be a pouring of a lot of resources to help that situation. And that will be called the honeymoon phase, where everyone is trying to help the situation. But then followed by that there will be a period when we call the disillusionment, where the resources started to come out, people will start to go back to their resources, and then the population will be left with very limited kind of resources to cope with the aftermath of the disaster. And obviously then after that, then the people will be starting to kind of do the reconstruction after the disaster occurred. In general, just to pick this picture from the first days of the war in Sudan. But I didn't want to put too many pictures that will reflect maybe some of the experiences of some of the audience. So it's a bit of a neutral kind of picture there. But who is affected by any disaster? There will be kind of like what we call the people who are in the disaster zone itself, will be the primary affected population. And there are secondary populations who are those people who are related to the primary victims of the disaster. So it's people who are living a little bit away from, they are not part of the disaster, but they were also related to people in the disaster zone. And there are people who are also at the tertiary level, or tertiary affected people, those people who take or provide services for those people who are in the disaster. So you or anyone who is providing social support will be party to that kind of tertiary affected population. This picture for, if you remember, the last year at the same time of this, there was a conference which we participated in Libya following the Derna disaster, where the kind of the hurricane hit the city, and you can see the amount of damage that happened in that. So what was the psychosocial support which kind of we want to deliver? It's kind of not a one entity intervention, but it's a collection of comprehensive kind of interventions that people need to deliver at the time, which should include psychological, social, and which will try to kind of limit the mental health impact of the disaster on the population. So psychological mechanisms, again, these are the way we're doing things, and Dr. Haitham earlier related to the issue of, or mentioned the most important thing is the command center, because all efforts that goes in to help people, because the population in the disaster zone needed coordination and preparedness. Now, one of the key issues of the preparedness is that all countries should have, or all kind of societies should have at least a prepared plan for how to respond to crisis. And this may be lacking, even if it's not at the top level of the governmental level, but they should be at even at provincial level or at kind of local service levels, or at different ministerial levels, there should be some sort of prepared plan for how to respond to crisis. Obviously, analyzing the resources and the needs of the population at the time of crisis will be key to providing the service, and psychoeducation and information provision is also an important element of providing psychosocial support. Building an information network is very important for the population we're providing with, because people may, at the initial phase, need only just to have some information, but where to go, who should they contact, how to proceed to the next stage. And then we should put in a system of referral that makes sure kind of people who need this kind of, for example, shelter, people who are sent to the appropriate place for shelter, those who need medication or treatment, they need to be referred to the appropriate place. And then mobilizing the community to the next stage. At the individual level, obviously people receive crisis and then respond to it through phases which are well known. The first phase is the shock, which is, again, I go back to Hassan mentioned that when he was in the Khartoum hospital, the phase of shock at that time, and then it will be followed by the reaction when everyone will be starting to recognize his feelings and then how to react to the crisis. And then there will be a period when processing time, everyone will start to resort to their coping skills and abilities to cope and their resources. And this way we need to mobilize much more resources to help these people to cope. And then there will be the recovery and reorientation back to the normal life in the next stage. If you look at these factors here in this slide, it just kind of shows kind of how personal factors as well as the environmental factors can also be important for how people respond to the crisis. So at the time of the confrontation with the traumatic event or any shocking experience, people will go back to their kind of personal characteristics, personal background, their ability to cope in general, and then also to some kind of extent to their family, to their kind of local society, local resources, and there may be also during disasters, what we call sub-traumatic events that happen. So after you have the disaster, there will be also some other traumatic events that can happen, losing someone, lost people got lost, your kind of all resources got lost. So this is another traumatic event. So the social support will help identify how you come to the end of or the outcome of that in terms of either you develop some of the psychiatric disorders or the majority of people might also be able to cope and get out of that situation without reaching the level of having psychiatric disorders. Resilience is quite an important aspect of life, but it's also resilience in disaster is quite an important concept. People talk about, at the end of the slide there, post-traumatic growth. So people who will go into a disaster situation will come out of it sometimes much more stronger than they were in the past. So, but these also depend on many other factors, including the ethno-cultural traditions, beliefs, and values. And one of the most important things here, I would say, research tells us that, for example, during the COVID, the majority of the coping research that has been done during the COVID period shows that religion is actually number one coping style that has been used across the world, not in one religion. So there are quite a lot of important factors that people can take on board from learning how to cope with disasters or crises. Obviously, there are other factors which, as I said, practices within normal societies, family traits, dynamics within the family, socioeconomic status of people who are very poor may become very vulnerable during disasters. Again, those who have experiences in the past with some traumatic experience may be much more stronger, they may be able to cope much better. So you have a variable response to disasters. These are the kind of the most common kind of disorders that happen during crisis or after disasters or crisis. Dissociation disorders or traumatic stress disorders, obviously is common, and anxiety, depression, and addiction disorders. And I'll just kind of say a personal experience after the revolution in Libya. We went to, after the initial phase, we went to the WHO for a period to the recovery and the rebuilding of the country. And one of the most striking kind of feature was the increased rate of addiction, which was seen immediately after the revolution there. And that was one of the difficult times for mental health services to recover. In general, social interventions go through this pyramid, which is understanding, first of all, the social and the basic needs of the society at the time, or the individuals, and then making provisions of those. Strengthening the community is quite an important intervention. So if you want to help the people, you first need to kind of understand their needs. You need to go to them and see where the strengths is within the society or within the community, and then help those who are in the community to become more stronger to be able to face the situation, because they will be the people who can help their own population with the situation is. So finally, just kind of to sum up that, I say that social interventions during crisis or following disasters are defined and well known through many international guidelines for that. They should be very clear kind of plan in countries to respond to the crisis, and even though wars are not kind of known when to start or how to start, or where they're going to start, but at least there should be a prepared plan for how to respond to the any kinds of crisis that happens, and that could help us kind of mobilize the resources at the time for developing better social interventions and outcomes. And as I said, coordination is the key. I'm 100% sure that kind of the command that has been developed, for example, in the Ministry of Health in Sudan, would be kind of the point where all the coordinated effort for improving or delivering these social interventions is quite vital. Thank you very much for this.
شكرا دكتور طاهر for enlightening us about the impact آثار النفسية للأزمات وكيفية التعامل معها. Our next panelist is Dr. Muhammad Walid. He is an ophthalmologist and is the head of the Syrian Sudanese Medical Association. He is also joined by his colleague Dr. Hassan Al-Sawaf, who is the head of the Syrian Medical Association, and they are going to share with us their experience from the Syrian war. تفضلوا.
تجربتنا في سوريا خلال الحرب التي حدثت في سوريا خلال الآن تجاوزنا 13 سنة. سنتحدث إن شاء الله عن تجربة القطاع الصحي في سوريا خلال هذه الحرب. ردي. سبحان الله، أثناء حديث الدكتور هيثم لاحظت أنه ما يجري الآن في السودان هو بالضبط ما جرى في سوريا. انتهاك كامل للأعراف، للقوانين الدولية، لاتفاقيات جنيف المتعلقة برعاية الكوادر الصحية والمؤسسات الصحية أثناء الحروب. طيب، عندنا في سوريا الآن حتى نتحدث بالأرقام، عندنا تقريبا 3 مليون بني آدم محتاجين لرعاية صحية في مناطق خارجة عن سيطرة النظام بالكامل. لا يوجد نظام صحي نهائيا في هذه المناطق. عندنا 7 مليون لاجئ، عندنا 4 مليون بني آدم موجودين في مناطق الشمال السوري. نحن نتحدث اليوم عن منطقة الشمال السوري، المناطق المحررة في سوريا، والتي لا يوجد فيها وزارة صحة تتبع لحكومة النظام السوري، وإنما جهود طوعية، جهود شعبية في هذه المنطقة. 4 مليون في منهم مليون معاق محتاجين لرعاية طبية متميزة ورعاية طبية خاصة، تقريبا 27% من المجتمع. دكتور خالد، السيستم شغال. سنتحدث بهذه الدقائق عن 4 نقاط. النقطة الأولى normative framework، اللي هي الإطار المعياري، الوضع القانوني، ما ينبغي أن يكون في حالة الحروب. الحروب ليس معنى الحرب أن يتم انتهاك كل شيء. هناك قوانين، هناك أنظمة دولية. سبقني الدكتور بروفيسور إبراهيم باني يتحدث عن اتفاقية جنيف لعام 49 والبروتوكولات لعام 77 والمسؤولية في الحماية كذلك. هذه الأمور معترف بها دوليا وواجبة التنفيذ. هذا ما ينبغي أن يكون، لكن الواقع، سنتحدث أيضا عن reality of targeting health sector in Syria. الواقع هل هو ما ينبغي أن يكون أم مختلف؟ سنتحدث عن الابتكار innovation in conflict affected health services provision في سوريا، وننتهي ببعض التوصيات. the international laws that protects medical facilities in times of armed conflicts. الاتفاقيات تحدثت عن كل شيء، تحدثت عن principle of distinction، مسؤولية التمييز. السلطة الموجودة في المنطقة عليها مسؤولية أن تميز أن هذا كادر صحي أو مؤسسة صحية أو رعاية صحية أو مريض، هي مسؤولياتها القانونية. مسؤولية حماية المرضى، حماية المؤسسات الصحية، حتى تحدث عن حماية الميديكال ريكوردز، هذه مسؤولية قانونية. وينبغي سيارات الإسعاف، نقل الأدوية، هذه كلها محمية بموجب القانون الدولي. بالطبع لم تكن محمية في سوريا ولا في السودان الآن حسب ما سمعت من سعادة الوزير. صور حقيقية كانت من المدن السورية. الحقيقة المرة التي كانت هي ليست فقط انتهاك القانون الدولي الإنساني في استهداف الكوادر الصحية والمؤسسات والمرضى، وإنما كانت الانتهاكات كانت تتم بأدوية أيضا وبأدوات أيضا محرمة دوليا مثل السلاح الكيماوي اللي يتم في الغوطة. ونحن الآن يعني قريبين من الذكرى السنوية لهذه المجزرة التي راح ضحيتها 400 طفل سوري في الغوطة، ماتوا جميعا، كانوا نيام ولم يستيقظوا. PHR Physicians for Human Rights، حنجيب نماذج من عند المؤسسات الغربية، الخواجات ماذا يقولون. الدكتور محمد أسامة البارودي الذي استشهد من أول طبيب استشهد في سوريا، تم استهدافه مباشرة أثناء عمله كطبيب. لم يكن يحمل سلاح ولم يكن معارضا ولم يكن يلقي بيانات سياسية، كان يعمل طبيب وتم استهدافه. تم استهداف كل الأطباء الذين كان يوجد شك أنهم يعالجون المتظاهرين المدنيين. من تورط في هذه المسألة تم استهدافه وقتل ورمي في الشارع أمام بيت أهله من الأطباء. PHR تقول أن 600 هجمة موثقة على المستشفيات في سوريا تمت، وأكثر من 1000 شهيد من الكوادر الصحية. في عندنا 700 طبيب من زملائنا استشهدوا وهم يقدمون خدمة الرعاية الصحية لا شيء آخر. أكثر من ذلك، كان استهداف الكوادر الصحية في سوريا هو هدف ذو أولوية. استهداف الكوادر الصحية، استهداف قادة الرأي، استهداف المفكرين، كان هدف ذو أولوية للنظام. ستستغربون عندما 3 دقائق، ستستغربون عندما تسمعون أنه في الدولة التي تساند النظام السوري عسكريا يدرسون أن الطبيب يعادل 9 ضباط من الناحية العسكرية فيجب استهدافه. تدريس في الجامعات يدرسون ذلك، يعني إجرام مؤسس. والموضوع مستمر حتى اليوم. الدكتور مجد الماز توفي، قتل في مايو الماضي. يقولون نظام صحي هش وهم يقصفون بالطيران والاعتداءات العسكرية وكذا. هو نظام حيوي وليس هش. نستطيع بجهود الدكتور عبد الله الأنصاري يتكلم عن نقطة مهمة كتير. لا نحتاج إلى دعوة لكي نخدم أوطاننا. علينا أن نبادر أن نخدم أوطاننا بكل ما أوتينا من قوة المجال متاح. الحمد لله هنا رابط مباشر، أي واحد يعمل فود سكرين على الاستهدافات في سوريا، كل مكان، زمن الاستهداف وعدد الضحايا في الكوادر الطبية. اجتهدنا كثيرا في إنقاذ شعبنا، في مساعدة شعبنا في المناطق التي كانت لا توجد فيها رعاية صحية. يعني حققنا الحمد لله إنجازات طيبة من ناحية. دائما في الرعاية الصحية في هذه الحالات تختلف المسألة عن الممارسة العادية كطبيب، تحتاج تمويل، تحتاج ابتكارات في العمل الطبي. نحن استعملنا في سوريا العيادات المتنقلة، استعملنا مراكز قابلة للنقل، استعملنا الأونلاين كونسلتيشن. دولة قطر مشكورة كعادتها، كانت دائما مبادرة في دعم سوريا المستقبل. ستذكر دائما جهود دولة قطر في مساندة الشعب السوري في الجانب الصحي وفي كل المجالات. إخواننا السودانيين كذلك أيضا في موضوع التعليم كان لهم دور إيجابي جدا. مجلس التخصصات السوداني، وزارة الصحة السودانية تعاونت معنا جدا حتى أنشأنا السيريان بورد فور ميديكال سبيشاليتيز يدرس حاليا خرج 336 طبيب ب 22 تخصص طبي مختلف، وخرجنا دفعة الشهيد التي استشهد في أول الثورة محمد أسامة البارودي، الآن الدفعة الثانية من كلية الطب جامعة حلب الحرة. يستحق التصفيق حقيقة. 52 طبيب، 26 طبيب و26 طبيب، 52 باسم الشهيد رحمه الله الدكتور البارودي. الحماية مهمة جدا تحدث عنها الجميع. نحن مشينا خطوات في مسألة الحماية من خلال تعزيز الشيء المميز اللي عملناه في سوريا هو تحصين المستشفيات. المستشفى هو هدف عسكري لابد من تحصينه وتدعيمه في أساليب كتير. نعمل أحيانا مستشفى داخل الكهف، أحيانا مستشفى في الدور الثالث تحت الأرض لأنه يتم استهداف المستشفيات بالطيران، أحيانا عمارة كاملة يكون المستشفى في البدروم حتى نأمن المستشفى. اعتبرنا مسؤوليتنا حماية الطبيب وحماية المريض. كان يقتل المرضى أثناء العمليات الجراحية. التواصل الدولي، العلاقات الدولية، التوثيق لما يجري. إخواننا في السودان أيضا نحن استفدنا من هذه المسألة بعد سنوات من العمل أننا لم نكن نوثق بالصور والفيديوهات أسماء القتلى، أماكن القتل. نقول قتل مريض أثناء العملية، ما اسمه، من هو، أين كانت العملية. مهم جدا التوثيقات لأنه يبقى ويثبت الحق. دقيقة واحدة وأنهي إن شاء الله. الدكتور حسن الأعرج مدير صحة حماة استشهد أثناء تأديته لعمله وكان راكب في سيارة إسعاف، تم قصفه بصاروخ مباشر على سيارته، الصورة في الأسفل. هاي أحد النماذج لأطبائنا الشهداء. حقوق الإنسان في المجال الطبي هي مسألة إسلامية ومسألة موجودة في تاريخنا وفي ثقافتنا، عززتها الآن القوانين الحالية، لكن موجودة ابتداء من الحقوق الأساسية الخمس: حفظ الدين والمال والنفس والعرض، وحقوق التنقل وحقوق العلاج إلى آخره. التوصيات، التعليم الطبي مهم للغاية، يجب أن لا ينقطع، استمر التعليم الطبي مهما كانت الظروف، واعتماده. الاستفادة من تاريخنا وثقافتنا في مسألة حماية المؤسسات الطبية وحماية الكوادر الطبية وتطوير الأمر. كذلك الدعم وتمكين اللاجئين في المناطق التي حصل فيها الحروب، حتى في المجال الطبي، في مجال التعليم ومجال العمل. متحدين نقف، متفرقين نسقط. شكرا جزيلا.
شكرا دكتور وليد للإضاءة دي بخصوص تجربتهم في الحرب السورية. شكرا دكتور وليد للإضاءة بخصوص تجربتهم في الحرب السورية. Our next panelist is Dr. Hadi Muhammad Abu Rashid. He is a pediatric oncologist and also he's an advisor to the Qatari Cancer Society. Fadl, the floor is yours. You can talk.
So you gotta see now we're gonna have two mics at the same time, one for the camera and one for the so it's okay. So just there is one one thing I'm not a pediatric oncologist. I'm pediatrician background. I did public health, just to make sure that I don't want to get a board that I'm not. Yeah. This is now you're gonna teach me how we do this together. How we have this. This will switch it off. Okay, yes, and this is on.
This is for the
Okay. I feel like when you do an interview on the TV, you have like 1 billion mic, so it's more. I think thank you so much. It's my pleasure to be here, and I pass the greeting from His Excellency Sheikh Dr. Khalid Jabbar Al Thani, our chairman, who would have loved come here, but he wasn't able. Regarding the topic of cancer control, cancer care, especially in the time of conflict zone or conflict times or humanitarian crisis. No, you cannot hear me. Okay. So in the time of crisis, cancer care in time of crisis, it's something that I mean, unfortunately, our area we've been. I think I'll just go there. Yeah. Much easier. And I'll keep this for the camera. Oh my God.
This is the camera.
That's okay. This better there. Okay. خلاص. الله العظيم خلاص والله يعني راح احكي بدون مايك والله كلكم بتسمعوني بدون اي شيء. ما انا من نص حلقه بصوتي بوجي باخر الحاره.
بس خليك كده.
خلاص طيب. So now is good. Now is good. Good. Excellent. Excellent. So see. So I'll tell you something. We are everyone from whoever has been in Aleppo. We are very loud people in Syria. We just talk very loud. So this is in our gene. We don't need mic. We have built-in God-made mic in our larynx. So regarding about the whole cancer control, cancer care, and humanitarian crisis, unfortunately, our region has been, let's say, plagued by this in the recent era. I mean, Sudan, and we should not, Syria, and we should not forget also Gaza and Palestine, and now is even Lebanon. The cancer patient are suffering in all those areas. So in general, when you have a human crisis or war, what are the major consequences? First, it leads to infrastructure damage. So, and cancer care and cancer control is a high demanding health system. So we are talking about specialized hospitals, preparing chemotherapy. It's not the usual, it's something you cannot, the infrastructure of cancer care is not simple infrastructure. It's high demand. And we're not talking about treatment, we're talking about lab, we're testing, diagnostic, and so on. And the Minister of Health of Sudan mentioned that we just had one MRI just recently because of impact. This is tell us that how much the crisis and war can impact this, the cancer care. The other aspect, the population displacement. Already it's difficult for people living with cancer to access services and to move around to these services. What about then if you go to be displaced? And the displacement, and then on the whole economical, financial toxicity of care of cancer that they have on their burden. And are they going to put the priority of their family, the livelihood, or their treatment, or their family members? This is it's a very difficult situation they will go through. And in addition to the let's say infrastructure and population displacement, is the healthcare professional shortage. I mean, they get displaced, they get targeted, they get killed, they get pulled to other services. And I think we remember all over the world. We are lucky here in Qatar that the cancer team continue to function, but in other places, I'm talking about COVID, the cancer team got pulled to other services. So this is, in the time of the war, all the staff that they work on cancer, they may be pulled to provide basic health need beside the cancer care, because they need to cover for basic health need. And the last one is the medication shortage. And I think it's been mentioned that $600 million medication has been stolen from the storage of. This is tell you the impact on war on the cancer care. This is the constraint that we can't, and I can talk about the initiative if you want. That could we overcome it if that's. So what I'm gonna now, I know I don't want to just put problems without solution. Okay, and this is problem that exists. What are the solutions? It's already been mentioned. The activation, the activating telemedicine and the virtual medicine. This is something that's highly valuable in the time of and I think one of the silver lining of COVID is that we got ourselves ready for telemedicine, and the communication, even the discussion on how they can overcome issues, the shortage of healthcare professional, the consultation internationally, and having Sudanese physician abroad work on this. Other aspect is the activation in primary care. So the primary care system means, yes, definitely that most of the cancer care is centralized, but when we activate the primary care, we can delegate part of the cancer care parts to the primary care with intense training or that they can overcome that in the time of the crisis. Other thing, really the international collaboration with entity to supply the medication. And there are WHO, the International Agency for Oncology Treatment, IOTP, the Union International Cancer Control. There are so many international organizations can work with a steady leadership. And I think that's the great thing that the Minister of Health in Sudan did is that they established that we have a steady leadership existing, that we can move forward into arranging the cancer care treatment. And here we should not forget the community aspect. And the community aspect, a lot of people focus on the cancer care treatment, chemotherapy, surgery, but there are early detection, and the community mobilization can really play a role in education. And yes, one of the things is the NGOs in the time of crisis, and we are all doing the same thing. Crisis doesn't come and leave after 3 months, 6 months. It stays for a long time, unfortunately. So that's why we need to work on the grassroots organization, to work with them as an NGO, to focus on community mobilization, community education of the community, of the earth detection, risk reduction. Some people, when they think of this, they say, come on, you are worried about the casualty and no treatment and no surgery. But trust me, if cancer is being detected early, any type of cancer, treatment is completely different. So that's why it's the importance of investment in grassroots organization and training community health workers. And also what we could do is really we need to put more and more to be more advocate, the local NGO, local organization to be more advocate, to put out the challenges that cancer patient or non-communicable disease patient out there to advocate and let people know about it. I mean, we totally understand that the priorities and the first aid and so on, but also they are suffering. We need to focus on that and without advocacy for that, without letting people know with video, with pictures, with numbers, no one will motivate for that. And I think I'll stop here and then I can follow later.
Thank you, Dr. Hadi. Our next panelist is Dr. Muntasir Osman, Director General of Health Emergencies and Epidemic Control, Federal Minister of Health. He will share experience on internal experiences during crisis and lessons learned.
طيب السلام عليكم ورحمة الله. في البدء أشكر الإخوة في رابطة الأطباء بقطر السودانيين بقطر. كده كويس؟ وتحياتي للأخ الوزير، الأخ السفير، ودكتور عبد الله، والأخت دكتورة مريم، وكل الإخوة والأخوات الزملاء الأساتذة الأجلاء. I will speak about part of our experience, internal experience during this war. Actually, Dr. Haitham spoke about most of the things that I was preparing, but no matter, I will start from the direct conflict that affected the country. The result was almost 13 million people forced move from their households to other areas. 2 million moved outside the country to be refugees. And the other remaining moved to more safe states. Unfortunately, like those who moved from Khartoum to Madani, then face the same problem, move to Sinja, and then move again to Gadarif, Kassala, and Port Sudan. These are all exhaustion to the people of the country. The result also including deaths, reported deaths of more than 3,000, and this is in the health facilities. Outside the health facilities, estimated more than 10,000 reported civilian deaths, in addition to more than 40,000 of injured, who traumatized, who seek treatment in some of the hospitals. This part of the result that affected the country, 50% of the land hard to reach area due to the conflict, militia area or direct conflict area. From what we observed in the first of the outbreak of this crisis, we started with serving the people, ensure that all the health facilities to be secured for the service and the supply system. In Khartoum, for example, we have brave people who were in front of the line with the same time with those who are fighting to provide the service, to secure the supply, and also to secure the health services, essential health services for the population. In the first days, we started this work with our colleague in Khartoum State and National Medical Specialization Board to provide the supplies, and also the cold chain, our colleague in the EPI. So it was smooth up to the 4th week. This is regarding the National Medical Specialization or Medical Supply Fund. But for the service itself, we found ourselves having this crisis situation, fighting within the health facilities, including Shab Tertiary Hospital, then Khartoum Hospital, Referral Hospital, and after that the SUDAQ, and after that the Al-Zarra. And you know these areas, most of the referral centers are in the center of the Khartoum state. Khartoum itself, Khartoum city, has been affected during the first days of this crisis and it was almost crushed by the militia, and this affects our essential service and also tertiary service. We started with volunteers in Khartoum State to provide the service outside this center area in the peripheries before also the same problem happened in these areas. I think the first thing that we faced, that no any protection for the health cadres. We lost from the start cadres, medical doctors, nurses who were working in the health facilities. After 7 days, they started to move to their homes, but unfortunately, they killed within their way to their houses. We lost also managers, like the director of emergency in West Kordofan. She was working, she was committed, very active, and working to serve her people there. Unfortunately, we lost her within the first 4 weeks. Our internal experience showed that centralization is a real challenge for us. A centralization for the reference centers that also have been affected. Almost 70% of the specialized referral centers like renal, cardiac have been affected. And this, the result was to move to have another new hospitals or referral centers like what happened in Medani immediately after the fight started. The people moved to Medani. Also the medical cadre and the health cadre and those who are managing the crisis and the essential departments in the Federal Ministry of Health, they moved to work from Medani as one of the stations for taking care or for leading and taking care of the provision of the health services. This also has been affected after November. You know what happened there. We have 2 minutes. طيب, what I can say here that the centralization affect us, affect the working of the health cadre, affect the working even of the leadership, the Federal Ministry of Health. The decision came from the senior to have decentralized station in 3 states, so we can move quickly, we can move with flexibility. I think this resilience gave us more room for working. The other thing, when we lost the National Medical Supply Fund, warehouse, it has to be also a solution for that. And at that time, we prepared like a format, including all the required from the medical supply, drug supply, and other machines that we are in need of to work. And thank you for Qatar, thank you for Saudi Arabia, and all our the countries that supported us during that time. I want just to have to say that the first organization, Qatar Al Khairiyya, was the first organization that called us and put all their supplies to us, that supported us during the 4 weeks, the first 4 weeks, availing the food for the patients and also for the health staff. In addition, the decentralization gives us more room, as I said, to have the supplies to fill the gap in this area of supplies, like the referrer of the renal centers, cardiac centers, and in addition to the infectious diseases. One of the challenges was the outbreaks. We faced outbreaks of cholera, dengue fever, malaria, and some of the vaccine preventable diseases. The people, the frontline people, deserve that to be brave to work in this situation, to serve the people, to contain this outbreak. They work with all the pillars in this challenging situation to contain the outbreaks of cholera. I think all of us observed that within 6 months, we contained the first outbreak of wave of outbreak of cholera by the work of the people within the community. The lesson learned that I can say, we have to prepare our health cadre to be ready for the distress of disasters. We have also to work to protect our health cadre during this situation. We have also to prepare ourselves for decentralization of the health services, health system resilience, including all the services from the PHC secondary care and tertiary care to be provided for most of the population if this has been happened. We know that we observe and we experience the peripheries conflict in Darfur and also in Blue Nile, South Kordofan areas, but it was the first time to have it in the center of the country. I will stop here.
Thank you. Thank you, Dr. Muntasar. Sorry that because we have very limited time. We have only around 11 minutes to end this session. So I don't know whether can we have extension for another 5 minutes more. Our next panelist is Dr. Ahmed Shadul, who is the Secretary General of Sudan Medical Association Board. And Dr. Shadul has an important role, a leading role in WHO. He was WR in Yemen and in, I think, Afghanistan. تفضل دكتور.
طيب بسم الله الرحمن الرحيم. السيد معالي وزير الصحة الاتحادي، السيد معالي وزير الصحة الولاية الشمالية، سعادة سفير السودان بقطر، السيد تشيف ميديكال اوفيسر محمد ومديرة النيرسينج ديبارتمنت، السلام عليكم جميعا. الحضور الكريم السلام عليكم جميعا. التحية أيضا لرئيس وأعضاء رابطة الأطباء السودانيين بقطر للدعوة ولهذا المحفل العلمي الجميل. المشاركة بتاعتي حتكون في تجربة مختلفة من 3 دول في موضوع اليوتيلايزيشن of a health service للبيس بروموشن. وانا افتكر انه الهيلث من كل الانترفنشن is very well positioned لانها تكون negotiation for peace. التجربة الأولى كانت 98 في جنوب السودان. By that time I was the chief health and nutrition officer في اليونيسيف. حصل a huge outbreak of measles with very high mortalities. والpeople were very much يعني annoyed and حتى الcommunity. We started to negotiate in what are we going to do. Started with يعني مقترح إنه we have to do vaccination campaigns. قبل الvaccination campaign كنا we started an initiative called بارجة السلام peace steamer and هي تتحرك من كوستي إلى جوبا. تأخذ 3 شهور في الفترة دي through which we provide immunization البداية، بعد ذاك expanded ل health services و psychosocial promotion. وما كانت enough. We started to negotiate the possibility بتاعنا to introduce a vaccination campaign against the measles والبوليو. And discussion started with the community, لكن we managed to reach an agreement between the fighting factions إنه ما يسمى بال corridors of peace. في corridors كده ما بيهبشوها لما تكون الأتيام ماشية. دي البداية. بعد ذاك بقى في اتفاق إنه during certain days يوقفوا الشلل اللي هي ما يسمى بال days of tranquilities والتحصين يستمر. شوية شوية we reached the area المكان في إننا can we negotiate a ceasefire? Unfortunately enough, we did manage to negotiate a ceasefire for the first time. Well, not only that, but يعني utilization of teams from inside Sudan and from outside Sudan through Lokichoki عشان يتلاقوا الأتيام داخل ويعملوا covering عالي جدا جدا. This was a real success والله. الشيء الجميل فيها إنه يعني كده شوية ما لقينا تشجيع شديد من الناس. في واحد من الكبار الناس المجتمع فقال لنا انتم ما تجيبوا تطعيم بتاع بقرة. قلنا خلاص، كلمنا الفيترينريز، عملنا تطعيم بتاع بقر. مع البقر بتجي الفاميلي كلها. كانت a wonderful opportunity to increase ف السيس فاير دي كانت النواة الأولى للنيغوشيشن اوف بيس بين جون جرنج وحكومة السودان، والحمد لله مشت لما آلت إليه يعني. This is الاكسبيرينس الأولى. الاكسبيرينس الثانية كانت في أفغانستان. أنا that time I was WHO representative in أفغانستان. برضو حصل ميزلز outbreak في المنطقة الطالبان هيلث اريا، وانزعجوا جدا البوبيوليشن وكده، وكلمناهم يا جماعه والله انتوا لو عملتوا فاكسينيشن الاطفال ديل ما بموتوا بالمستوى ده يعني. ف we started the negotiation. قالوا اوكي خلاص، لكن ما بنقدر الا نحن نناقش فوق. المهم النقاش بدا بالكوميونتي، ثم اللي بيسموهم الفيلد كوماندرز اللي قاعدين في الفيلد بموافقتهم كده بدينا small campaigns. بعدين they were very happy. They started to talk about it. We reached the chief commanders بتاع Taliban والauthorities we had a discussion with them. وريناهم يعني المحاسن بتاعت التطعيم وكده. قالوا ما دارين تطعيم بس، دارين تطعيم، دارين معاه خدمات تانية. قلنا كويس، ممكن نجيب خدمات تانية. وقالوا دارين يدربوا لهم ناس وندربنا لهم ناس. لكن عشان نصل الحتة دي كان لابد من إن ناخد إذن من اليو إن، ناخد إذن من الدبليو اتش او، ناخد إذن من الناتو، ناخد إذن من اليو اس ارمي. ويمكن في البداية وجدنا صعوبات، لكن في النهاية تمكنا من إنه نقنعهم. بل مشوا لأكثر من كده. ناس الناتو قالوا نحن ممكن نديكم أفراد من الجيش يخشوا يطعموا. قلنا لهم لا، بس هنا دي خلاص، بس انتوا ادونا السيس فاير والكوريدورز اوف بيس. وفعلا عملوها علينا، لكن we have to give them التواريخ في فترة طويلة جدا. يعني نحن لو حنعمل حملة في جانوري نديهم الليلة التواريخ بتاعتها والمسار بتاعها. الحكاية مشت معانا كويس جدا جدا. ومن الكامبينز بتاعت الفاكسينيشن مشت لبروفيجن اوف هيلث سيرفيسز. والطالبان في حاجات تخوفوا منها. يعني قال لنا قصة الفينجر ماركينج ده ما دايرين، والكتابة اللي بتعملوها في الباب دي بتاعت الأطفال الخمسة أقل من 5 أعداد وكده، الدائرة دي ما دايرين. ليه؟ في شنو؟ قال والله دي تعملوها هنا بتدي الستلايت وبيضربونا بالليل. فوافقنا ووقفنا الحاجة دي، لكن نجحنا جدا جدا في إننا نعمل الترست، يعني يقط الترست معاه، وبقى في فول فاكسينيشن وهيلث سيرفيس بروفيجن. وبقوا وصلوا مرحلة بتاعت إنه يدون الماب بتاعت الألغام الموجودة في الفيليج يعني. المسألة دي جزء كبير منها كان sponsored by بيل جيتس. فقال داير يكتب خطابات لهم ويكتب كده. قلنا له القصة دي خليها شوية. المهم حصل اجتماع في أبو ظبي بدعوة من بيل جيتس، ووريناه إنه مسألة الفينجر برينت والأشياء دي. قالوا ما دايرين ننزله. بعدين التريسابل بوكس فاكسين دي برضه ما دايرين. فتفهم الحاجة وقال طيب إذا هسه جبنا لهم فاكسين من الدول المسلمة حيقبلوا؟ قلنا ولا حيقبلوا أكثر كمان. immediately من الاجتماع ده مشى قابل الحكومة في أبو ظبي وجاب منهم $50 مليون للبوليو فاكسين، ومشي السعودية جاب برضه $50 مليون الفاكسين. الحكاية دي ساعدتنا كثير جدا. والنيغوشيشن ده أخذته قطر وأولويز بايونير، وعملت أوفيس للنيغوشيشن بتاع البيس بالنسبة لأفغانستان هنا في قطر، وبدأت التجربة الثالثة كانت في اليمن. برضو I was a WHO representative there، وحصل لنا outbreaks. المرة دي ما ميزل دنجي وكوليرا، وكان مشكلة كبيرة جدا جدا. يعني الزمن ذاك اليمن كان under complete siege، ما في لا أرضا لا جوا لا بحرا، no way تصل اليمن. الهيلث كانت affected جدا، لكن سمح للWHO تكون responsible من البروفيجن of medical supplies وكل الهيلث سيرفيسز. فاضطرينا نعمل warehouse في جيبوتي ونرحل الأدوية من جيبوتي لعدن وللحديدة. عدن under الجفرمنت كنترول، والحديدة under الحوثي كنترول. عشان تعمل الحاجة دي لازم تاخذ إذن من الحكومة، تاخذ إذن من الحوثيين، تاخذ إذن من قوات التحالف. والحمد لله، وقلنا لهم يا اخواننا الهيلث دي خلوها كده نيوترال. الكلام اللي قاله السيد الوزير قبيل انه خلوها نيوترال، الدواء والحاجات دي لازم تصل اي واحد في مناطق الحكومه وفي مناطق الحوثي. فوافقوا على الحاجه دي كلهم. و we started to move الهيلث كونفويز فيها distribution of drugs و supplies و medical equipment وستاف برضه. والحمد لله الناس نجحوا فيها جدا. بعدين we started to negotiate انه it's not only medical، نحن دارين البريفنشن، دارين الووش انترفنشن، دارين الفود عشان المال نيوتريشن، وبقى الكونفوي كبير هيلث نيوتريشن اند ووش، وكان سيف جدا جدا الحمد لله. والتجربه مشت، وافتكر هسه هي بقت الاوبورتيونيتي فور negotiation further negotiation of peace. في الختام انا عايز اقول انه this process يعني حصل من خلاله improvement للاكسس، و we were able to provide the medical supplies and needs، و we were able to support the health workforce، و we were able also to provide a service to the population، و to build a health system resilience، و promote a psychosocial support. ودي حاجة مهمة جدا جدا during a crisis برضه. و to initiate a peace discussion. و in conclusion أنا أفتكر this is a wonderful opportunity for health to lead a process for peace promotion. ومن المهم في البروسيس to engage الcommunity و to be يعني to think out of the box to come up with innovations and to be flexible. Thank you very much.
Thank you, Dr. Shadur. I think we have a time بتاعنا is over، لكن can we take about 5 to 10 minutes؟ و to be fair enough أنه أحسن ندي جزء للباناليست سؤال وسؤال لل Q&A for the audience. فنبدأ بسؤال للباناليست، وممكن أي واحد منهم يجاوب. I don't need all of them. What mechanisms should be in place or developed to facilitate better coordination between local health authorities, international organizations, NGOs in developing an effective health care during crisis? I think Dr. Muntasir, or yes, or تدينا برضو البرسبكتيف of Syrian. دكتور منتصر. اوكي.
احنا من التجربه في السودان الكوردينيشن very tough يمكن area to work on. في السودان ال EOC بالنسبة لنا at national level and also at sub-national level كانت لنا one of the solution to coordinate between the Ministry of Health, the UN relevant those who are working in the health and also the international and national NGOs. فواحدة من التولز اللي استخدمناها regularity of the EOC meetings for actions and decision making. The other way, it is a health cluster meetings and also health cluster panel. يمكن the other area, some of the international NGOs زي يعني بيحبوا يكونوا موجودين في الهيلث كلاستر أكتر من إنه يكونوا موجودين في الإي أو سي، يعني كأنه ده government area وده Okay, يعني the same to be in the UN area, participating actively in the UN area. So the national health cluster is another modality. In addition to the high senior level coordination between His Excellency Minister and the other UN rep in the country, and we have not regular some meetings that all the rep with His Excellency the Minister participated for the cholera response to have more support resources for cholera response, financial, technical, and also supplies. This is two areas.
Thank you.
Okay. So I can, from perspective of nonprofit organization, NGO, the point of coordination is very important, and I think what's unique about Sudan is that you have this and that you have this entities is already functioning and having everybody on board. That when international entity want to work with entity, they don't need to work with 100 different entity. They work with one committee that they can know what are the needs, so they present the need in a proper way and they function in it. And as a public facing and grassroots organization, what we can what I could add a layer that could help is and I think you hint on it with the NGO. They want to be on that board. They don't want to be in the other board. They don't. Some of the nonprofit organizations, they have this mandate. They can only support or be in a committees that it's not related to government by any mean. And that's despite that, to have the leadership in health for better health in Sudan, it's you have to go with the Ministry of Health. So having that connector, the facilitator, the nonprofit organization, the national one or the coalition or the health sector that you have, the grassroots organization can bring a lot of support, and they play a role in advocacy. One of the advocacy, the voices of advocacy of nonprofit organization usually reach far without any, because this is their mandate, and usually nonprofit organization they have this. Let's say the umbrella or open check that they can open up and share their voices without any gates that stop them from sharing their or let's say red tape of sharing the problems, and that add transparency to it, and that's what they call also for international funding. There are some foundation that they channel all their support. It has to go through a nonprofit organization. They cannot go through the government entity. So this is what I felt. And also nonprofit organization, they have this soft power. They can work at the level of policy and diplomacy without being classified into certain blocks. That's what they can add to that layer also.
Thank you. I think now it's time to have questions from the floor. Anybody? Okay. Yeah.
Yeah.
First of all, I'd like to thank all of you for coming today. I will not mention names, but all of you are welcome. The second thing, I'm Dr. Ahmed Zaro from Palestine, from Gaza. What you're talking about in this group today for the crisis management, I was thinking when you were talking that I was really hoping that there will be one of you or someone from Gaza will be with you to talk about the experience that it's done. And really, I'm so happy that this is happening for Sudan, for Syria, that they're talking about something really did. And really, they did something good for their countries. And I hope that one day, one of us from Gaza will talk about the experience that it's done in your seats. Thank you so much for
Anybody else? Tara.
Assalamu alaikum. This is Ala Mudathir. I'm the Director General of International Health. Allow me to speak in English so we save the time for translation. I just want to maybe thank you very much, all of you, for the very informative discussions. Just from the word complex crisis is what I actually got from this term. Dr. Muhammad Tahir, you were explaining the disaster and the nice curve you were showing us, the honeymoon and the drop. I think in Sudan specifically, I was just trying to stress on how there were multi-crises in place in the same time. It was not just the war. It's because it was started before even the war. We had a fragile infrastructure, and then war come and make it worse. And then, unfortunately, because of a very important terminology that we really need to put while we're thinking ahead, which is climate change. Climate change is putting so much pressure on the health system, and I think we really need to put it in our future planning. This will take me to the next bullet. I'm sorry, Professor Ibrahim, that I think I believe, as Dr. Ahmed Shadul was stating, that we really need to be more focused on a more innovative approach and result-oriented, but without compromising the future result of these interventions, of the current interventions. Because if we kind of always depend on the humanitarian support, we will be left with nothing after the war is ending. So we really need to put into consideration some developmental aspects while we think humanitarian support. We really need to make sure that we are making the maximum use of the, even if it's poor, but existing infrastructure. We really need to make the maximum use of it. And hereby, I would like to express my gratitude to all health workforce in Sudan for putting their trust and their faith in the Federal Ministry of Health as a regulating authority in the country. I think this kind of mutual trust had made us here today to discuss very frankly, despite all the political affiliations, everyone is really putting Sudanese people ahead. And then the scarce resources. There is this limitation of the scarce resources that everyone needs to pay attention to. We have competing priorities. Here my brother is stating Gaza. We never forget about Gaza. We never forget about Gaza. Gaza is in our heart. As well as Syria, Yemen, Libya, every place really is suffering now. We look ahead at it and we think that we really need to make sure that we are learning from each other, making sure that the experience is well shared. This is the least we can do. And I think for the scarce resources and with the competing priorities in the region and the globe, we really need to put into consideration that we really need to push towards depoliticization of aid. I think we really need to rethink aid, how we do get the aid. And I think His Excellency previously illustrated about how we receive this fund from Qatar while we feel well dignified. We never feel there is this limitations, conditions, grant management issues. These things really is limiting the maximum
Thank you. Singo, may have a last comment or Your Excellency? A conclusive comment?
Thank you very much for the panelists. Really, we have learned from the discussion, experience from Sudan and from Syria, and all the experience from different countries through Jadul. Just some of the reflections. First reflection, it becomes like the wars and conflicts in our region become like a norm. Over years now in Syria, in Libya, in Sudan, in Gaza, and I think this needs some sort of transformation in the modality and methodology of managing the health in conflict area, in managing health in such area. Like the example just mentioned by Ala, I think no clear demarcation between humanitarian and developmental. International organization, even UN organization, come with these very short interventions. In Sudan, for example, this will not work for Sudan. In Sudan, for example, we need, for example, to invest in health workforce. As example just said, if not investing today, it will become a problem tomorrow. We need to invest in infrastructure. They will call that equipment, for example, is the developmental. But a patient with renal dialysis just now need interventions. This sort of shaping the humanitarian response in conflict setting. Even when we read, like, for example, Sphere project is built out around there in the camp with IDP population. If we look at Sudan, for example, 25% of the people of Sudan now are IDPs, more than 10 million. But 80% of these people are within the hosting community, not in camps. From the first date, I had a meeting with WFP. If you would like to see the people of Sudan in the camps and to provide food for them, you will find them. Try to adjust and reform your interventions for humanitarian response in such country. I think the experience of Sudan is unique. Almost 80% within host community. If you would like to support the IDPs, support the host community, support the infrastructure. The last point I would like to raise is don't give up. ونحن رفعنا شعار رغم الحاصل لا نواصل. Don't give up. Try your best to do what you were able to do, and even sometimes try what is impossible to do. Thank you very much.
Thank you, Dr. Haitham, and special thanks to our. All right.
Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. It's from Medina al-Baki, Senior Consultant Family Medicine. And first, I would like to thank the panelists for their contribution and their experience. And I would like to go more deep in some reflection and to talk specifically on the direct vectors who have proved to be the most effective ones. And this is derived by my profession as family physician. The first reflection was the reflection during the crisis of the COVID. During the crisis of the COVID, for example, in Qatar here, teams were established to function and work on the COVID patients. And during this time, the heads of the team and those responsible for the management of the camps and of the areas which were made to keep the patients safe and to put them in semi-quarantine conditions have proved that family physicians has played the most important role in caring for these patients. And the teams that have a family physician, for example, resident artery, does not need to refer to the so many specialties that are calls from other specialties. And this reflection started first from Hassan Mary Hospital and then extended to the rest of the team. So one of the most important things is that all the activities that aims to work on crisis must depend these have been brought from so many countries. But still in our area, it's not well taken into consideration. The second group, which was proved to be very effective, is the local community health workers. And this experience has started from Japan post-war in 1948, and then extended to so many other countries. This second group also needs to be considered for the training and for being they are very cheap, they are less or least expensive ones, and they are themselves elevated from the poverty by being employed in the healthcare unit area. Pushing a lot of teams without having public physicians and without having local community workers does not work very well and is considered non-effective. Thank you.
Thank you, Dr. Abdul Bagi. I think there is a question from the floor. I am going to read this question and see who will answer it. How you can prevent future collapse of the healthcare system in crisis situations, and how we can make the healthcare provider safe and confident to provide help without worries. I think the resource. Who want to answer from the panelists to answer this question?
Thank you. I think in response to this question, we need to go back to what has been said by His Excellency Dr. Haytham. First of all, the key element of having any health services is having knowledge about the needs of the population. Dr. Haytham said we should normalize the feelings about the wars, but I think we should normalize our response to the war rather than, because wars, I mean, most of us here did not think at all that we're going to have a war in Sudan at the time when it happens. Maybe other people in different places, for example, kind of a friend from Gaza, war has been there, so they have developed their resilience. Even the health services there and the system has been developed to kind of cope with any crisis and wars that's happening all the time in the region. So I think preparedness is a key factor, first of all. Second is we need to have really strategic plans for how to respond to different crises and different disasters that can happen, whether natural disasters or man-made kind of disasters across the board. And again, we need to think about our own resources. It's been mentioned earlier as well that kind of we need to develop on our own resources. Dr. Haytham also alluded to this, is that the issue is the local society's needs are different from different place to different area. Even in Sudan, there are cultural needs or health needs in the north that are different from the west and different from the east, and we need to take those as well on board in planning the health systems that will be able to respond to the crisis in the future. And I think, again, a coordinated effort between different organizations. Health is not only about health, but we need also social care to be very well embedded within the health system or coordinated with health systems, and also other kind of organizations and ministries within the country. Thank you very much, but if other people want to add.
Thank you. I think the time is limit. We have, is it okay? Very short, 1 minute, please. Okay. I think the understanding medical neutrality is really, it seems that not everybody is familiar with this. It's not commonly used. But now I think this is a starting point from this conference. Now we should advocate for it now. We should be trained. We have to train, especially the combatants, the military should be aware of this terminology. What do we mean by medical neutrality? It means protection, okay? Protection of civilians, protection of the healthcare workers. And we need to train our next generation also in medical ethics. Dr. Azza, she came with this. I think you must have some sort of workshop or talking about ethics and in your series of seminars, and I think we'll have one webinar about this. So advocacy training. All right, I think this will be our. Okay.
Thank you. But I think there are factors that actually, if they're existing, they will make the people much more resilient. And maybe, as you said, for example, certain nations, those who has been subject to traumatic events before, they come out with post-traumatic growth, they become much more kind of resilient. So I think, yes, but that is saying kind of, even if you look at the people from Gaza, the resiliency actually in Gaza is amazing. I don't think there's no research, nothing, but I think it is. I will just give you an example. I was actually walking into the ACC one day kind of to go to check my eyes, and there was a child who was coming from Gaza who was being injured, severely injured, was including his eyes, and he was taken by his mother in. Everyone who was coming at that time was looking at the baby because it was so disfigured. And the amount of resilience I saw in that child and the mother is amazing. They were talking to everybody. They were not seeing what is happening to them as actually it's just an experience. And that's resilience. That's how you protect yourself from being able to, to be damaged or to be kind of psychologically impaired by the events. So yes, there are societies that have much more kind of factors that would help them. Resolving to kind of like the more family compact people would have much better resilience. If you are much more kind of knowledgeable, if you learn more, you can also become much more resilient. If you have, the personalities are just factors, but they're not kind of the most important thing in the society. Other factors such as religion, the more the social is cohesive, or the community or society is cohesive, will also be a protective factor. So these are the things which can make some societies much more resilient. The fact that I mentioned kind of countries have different kind of levels of risks associated with disasters, but there are also factors which are measured on the societies and countries about their level of abilities to cope with pressures. I think Sudan is not one of the best kind of countries to be able to be honest, in responding so far, up till now. But let's hope then after the war will be much better than that. Thank you. Thank you, Asma.
Thank you, Dr. Tahir. And I think it's now time to come to an end, and special thanks to our panelists, our esteemed panelists for sharing their experience, and also for the whole group in engaging in this discussion, very interesting discussion. I look forward for more discussion about especially medical neutrality. Thank you.
Thank you so much. So thank you so much. Many thanks for our panelists, and grateful thanks to our distinguished guests because you stayed for the whole panel discussion, which reflects the dedication and endless support. Many thanks. Thanks for the audience. We'll now go to lunch. for half an hour. We'll reconvene at 1. Please remember to sign out and then sign in when we come for the next session. Thank you so much.
اللابتوب ده عارف يستخدمه؟ ايوه كيف